Ladies and gentlemen, on behalf of InVivoScribe, we welcome you to this webinar organized by AMP, the Association for Molecular Pathology. Our program's title today is Utility of NGS Assays for the Evaluation of Lymphoid Malignancies. We are very pleased to announce that in today's webinar, we have a presenter from the United States as well as a presenter from Canada. Please be assured that a recording will be made available of these presentations. We encourage you to ask questions in real time using the chat feature so that if time permits, we can address them at the end of the presentations in a question and answer session. Our first presenter is Dr. Yury Monczak, PhD. Dr. Monczak is the co-director of Molecular Diagnostics Laboratory at Jewish General Hospital and an assistant professor of medicine at McGill University in Montreal, Canada. He received both his master's degree and PhD from the Université de Montréal. After that, he completed a fellowship at the National Cancer Institute, NIH, in Frederick, Maryland. He has a particular interest in gene regulation during cellular differentiation. Dr. Monczak's presentation is titled IGHV Somatic Hypermutation from Sanger to NGS. Our second presenter today is Dr. Bevan Tandon, MD. Dr. Tandon is the Director of Cancer Genomics at BioReference Laboratories. He holds subspecialty board certifications in both hematopathology and also molecular genetic pathology. Dr. Tandon's training in hematopathology consisted of an intensive clinical fellowship and instructorship at the University of Pittsburgh School of Medicine under the guidance of WHO lead author Dr. Stephen Swerdlow. His training in molecular genetic pathology was subsequently conducted at Washington University in St. Louis School of Medicine under the guidance of Dr. Eric Dunkovich. Dr. Tandon completed his general residency training in anatomic and clinical pathology at Northwestern University Feinberg School of Medicine. Dr. Tandon previously served as Director of Clinical Molecular Diagnostics and Staff Hematopathologist at the Molecular Pathology Laboratory Network. Dr. Tandon's webinar presentation today is titled Utility of NGS for Routine Clinical Laboratory Evaluation of Lymphoid Malignancies. I am now pleased to turn the time over to our first presenter, Dr. Monczak.
Good afternoon, good morning. Thank you for the opportunity to address this audience. So the talks are quite full, therefore without further ado, I will start. First, the disclosures. A sponsorship by InVivoScribe enabled me to do this presentation. Let's start with a bit of molecular biology, which is actually the basis of the two talks. We're going to look very briefly on the way that every B lymphocyte identifies itself based on immunoglobulin heavy gene rearrangement. This is crucial to understand all other testing in this field. So the somatic germline heavy chain gene of the immunoglobulin locus contains three basic modules: the variable region, the diversity region, and the J region, or the junction region. And these in every B lymphocyte rearrange according to a random process, or more or less random process. So for example, B lymphocyte number 1 might randomly choose one of the various V regions, one of the various D regions, and one of the various J regions. I've presented only 3 of each, but it's a lot more complicated than that, and I'll show a slide a bit later on. B lymphocyte number Y, one of the first things that it does when it differentiates, it again will rearrange the VDJ modules. Therefore, randomly, perhaps it will choose V3, combine it with D2, and combine it with J2. And so forth for a third B lymphocyte, and so on and so forth. The permutations and combinations are vast. Therefore, every B lymphocyte gets a unique VDJ rearrangement. The V, the D, and the J regions have various lengths. The sequences differ, which allow these B lymphocytes to produce the vast array of unique immunoglobulins or antibodies. So we can say that the V, D, and J rearrangement is like a molecular fingerprint. So every B lymphocyte will have a unique fingerprint. This is the more complex schematic of the VDJ area of chromosome 14. So we can see all the various V region segments. We have the D region segments that are located here, and then we have 6 J regions that take part in this rearrangement process. We use a set of primers to amplify the VDJ area once it rearranges. And so as I've indicated, since the VD and J regions are all different and different sequences, the lengths of the fragments will differ depending on the actual rearrangement. So for example, when a B lymphocyte at some point acquires mutations that give it growth advantage, these cells will expand more than others and will create a clonal population due to clonal expansion amid a flurry of normal B lymphocytes. So if we look at the fingerprints, we can see that in the middle, we will have the initial clone on the left side. All of the progeny clones will have the identical VDJ rearrangement, the identical VDJ sequences and lengths. All the other polyclonal populations will have different VDJ rearrangements. Therefore, they will have a different length of the VDJ fragment. So all of these in the middle, they have an identical VDJ fragment. Therefore, if we carry out a PCR reaction on a set of B lymphocytes where there is a predominant clonal population, we can see that we can get either smears or discrete bands buried within a smear. The smears themselves represent the polyclonal population of B lymphocytes. The smear is basically made up of the unique sequences or fragments of every single VDJ recombination event in that cell population, whereby here we can actually see the smearing in the background, which is all the polyclonal B lymphocytes with one predominant band. It's the clonal VDJ rearrangement that is characteristic of the clonal population of B lymphocytes. Now we can sequence that band in order to determine what is the actual unique sequence of this rearrangement. So let's get on to the CLL phenomenon. And recently it was identified that sequencing of the V region and comparing that sequence to the germline version can actually predict the outcome of a patient that has CLL. We've all heard of the non-hypermutated, that was the official scientific term at the beginning. Presently it's called unmutated or UM, whereby people with unmutated V regions have an overall survival of approximately 9 years, whereas as patients suffering CLL that have a hypermutated V region in the clonal population of B lymphocytes have a much longer overall survival. So here we have a good prognosis and a bad prognosis determined quite easily depending on the sequence of the V region. Now, the definition of non-hypermutated or unmutated is that the homology between the V sequence between the clone and the germline version before rearrangements and hypermutations has to be greater than 98%. When we refer to something as hypermutated or mutated, then the homology between the V region of the clone and the germline sequence is less than or equal to 98%. So there's two ways of determining this. We started off about 10 years ago doing regular PCR and Sanger sequencing. It's a very rapid and inexpensive method. However, it could lead to some problematic situations. Recently, 2 or 2.5 years ago, we switched to next generation sequencing. And although it is slower and more costly, it is what we found to be a lot less problematic in certain situations. So let's look at both methods, and we sort of retrace the steps that we took when we switched from Sanger sequencing PCR to next generation sequencing. people that do B-cell clonality analysis have heard of the BioMed2 protocol that was published in 2003, I believe, by Dr. Van Dongen, a huge study which sequenced all the VDJ regions in the germline. A set of primers was created. It's all published. That allowed the amplification of the vast majority of any type of VDJ recombination. So you could detect theoretically over 99% of all B-cell clones that underwent some sort of a VDJ rearrangement. The basis of this was to have primers that are specific for the V region and primers that are specific for the J region. As I've illustrated here, the primers that are on the leftmost side of the V regions are in the FR1 area, and they, as you can see, sit within the V region. They can amplify a fragment of the VDJ recombination, and then all we need to do is do a Sanger sequencing of this area in order to read the V region sequences and then compare them to the germline. The problem that we had with this type of analysis is that inherently we miss the 5' most region of the V module because the primers are within the V region. Therefore, if we want to compare the level of homology to germline, and we've only sequenced part of the V region, well, we could be getting a false percentage of homology. If we have several mutations or hypermutations that occurred outside of the region that was amplified, well, we're not going to calculate them into an overall percent homology. Therefore, something that with this technology could be hypermutated, in reality could be over the 98% homology due to the sequences that have not been read upstream. Therefore, we could have false interpretation and false results coming out, whereby a patient could be deemed hypermutated, whereas in reality he's not hypermutated. And this is something that next generation sequencing has solved, although there are similar technologies using regular PCR and sequencing that address this issue. The next-gen sequencing technology that we've used actually uses primers that are outside of the V region. They're upstream of the V region in a so-called leader sequence. So by using these primers, we can actually amplify the whole area, including in the vast majority of cases, the entire V region, and therefore we obtain the mutation status of the entire V region that we can compare to germline. So this now avoids the problem of exactitude. We do calculate the percent homology of the whole V region. Now let's look at some of the results that we had from the past. This is using regular PCR and regular Sanger sequencing. And as you can see, there are several clones that we obtained. These are several CLL cases. And all of them do have a clonal population of B lymphocytes characterized by a clonal band or a clonal fragment of the IGHV gene. If we look at one specific case, we have a clonal fragment. It's easy to sequence this fragment. And if we look at the actual Sanger electropherogram, we can see a very clear and nice distinct sequence that we can then analyze for a deviation from the germline sequence. However, the way we do that is quite simple. We copy the sequence of the V region, pop it into one of two major websites. So as you can see here, I've pasted the sequence into the website. It's the IMG TVQuest website, which is probably the most complete and most well curated data analysis program that's freely available to anyone on the internet. And we get, within a few seconds, a result whereby our sequence is compared to all known germline sequences. So the original sequence is found over here. and the actual data that is interpreted later on is presented over here. We can see that we have 100% identity. The V region that is present in our clone is the IGHV 333 allele 01. There's a ambiguity. It could be either allele 01 or 06, but that's not the point of this presentation. The software also gives you what J fragment was used and what D fragment was used. However, the diagnostic side is this fragment over here, the V region, and the software tells you that you have 100% homology between our clone and the germline sequence. Therefore, this patient has an unmutated IGHV somatic hypermutation result. So it's a poor prognosis. Another website, the IGBLAST from the NIH, has a very similar website where you pop in the sequence, you press start, and within a few seconds you get a similar result. You can see here again the same sequence gives the same result, IGHV 333 allele 01, the D region, the J region, and furthermore it tells you afterwards over here what is the homology. So there it is, 100% homology, so both databases give the same result. If we look at a case whereby we don't have a clear clonal band, well, of course, you can't sequence that and you get gibberish. So that's uninterpretable. The problem arises, and this is where next-gen sequencing comes out as the winner, is when you have biallelic or biclonal or oligoclonal populations of B lymphocytes, as this case over here. You can see two fragments, one on top of another. Probably a biallelic rearrangements of the B cell clone. You could go the long way and actually take a razor blade, slice out one fragment, slice out the other fragment, and sequence each one individually. But this is good only when you have two distinct fragments. Sometimes the distance between one fragment and the other, the size is very similar that you cannot actually separate it on an acrylamide gel. Therefore, you're stuck with an electropherogram, which actually sequences both fragments together, and you get gibberish. In this case, you could try other primers. It's a very tedious method, and we have found that by switching to next generation sequencing, we avoid these problems. And I'll talk about this now. So about 2.5 years ago, we switched to NGS, and we found the transition very easy. Although more expensive, you get a lot more information out, and it streamlines the lab work tremendously, and it eliminates the problems caused by biallelic or oligoclonal populations of B lymphocytes. The typical data that one gets from the analysis is the number of molecules that have been sequenced. So here, in this case, it's over 350,000 IGHV molecules that were sequenced. We can see the coverage of the V region that was sequenced. Since we're using leader primers, we are sequencing the whole V region, or practically the whole V region. We can see the actual sequence of the clone. Therefore, just by copy pasting this sequence into the IMGT or the IGBLAST databases, we can actually have the analysis done in relatively short time. We get the V module that has been used in this clone. In this case is the IGHV 439 allele 01. And then the sequence checks whether the whole sequence is in frame and whether there's a stop codon present or not. So in this case, it's sort of counterintuitive. The question is no stop codon, and the reply is yes, which means there is no stop codon. So this is very important to verify because only productive alleles are to be used for SHM analysis. And one of the final results that you can see here is how many of those 350,000 molecules sequenced, how many of them had this exact sequence. We can see here it's over 60%. Therefore, we have a nice clonal population of B lymphocytes here. Now, the business end of the analysis is the actual mutation rate. Here we can see that it's 0%, meaning it's 100% homologous, meaning it's non-mutated, therefore poor prognosis. In a more graphic form, you can see that of all the VDJ molecules that were sequenced, there's a vast majority of the molecules. We saw over 60%, and this is represented in a graphical format. Had we had several predominant molecules that were sequenced that appeared, then we would have many of these bars scattered throughout this graph. Let's have a look at one biallelic or biclonal or oligoclonal population. So this, since we sequence every single molecule, well, we get, as we can see here, 2 molecules that are present in a vast excess compared to all the others. They can be analyzed according to some guidelines that were published by the European Research Initiative on CLL. The first guidelines were published in 2011. There's others that were published in 2016, and an update recommendation how to analyze either monoallelic or biallelic clonal populations that came out in leukemia over 2 years ago. So if we return to this case, we can see that I've labeled it as the major clone, present in 34.5% of the fragment sequence, and the minor clone is slightly half a percentage point smaller. Since they are present more or less in an equimolar quantity, you could surmise that this is probably a biallelic rearrangement. If we have a look at the sequence of both of these molecules, we see that the major clone here contains the V region IGH V16901, and it doesn't have a stop codon. It's in frame, and we see that the mutation rate is 0%. Therefore, it's 100% homologous to the germline. Poor prognosis. If we look at the minor allele, which is present only at 34%, we could say, okay, it's also unmutated. However, the key thing to check is whether you have a stop codon and is it in frame. It's in frame, however, it does have a stop codon. Therefore, this sequence would probably not produce a immunoglobulin molecule, a protein. It's non-productive, therefore it is not taken into consideration when you measure the hypermutation level of the V region. Therefore, in this case, you would only look at the initial, the major clone over here, which is a complete productive allele. So we have no dilemma. The major clone is productive. The minor clone is non-productive, so it's not considered for SHM analysis. Here we have another case where we have a major clone that is at a level of 41% of all fragment sequence, the minor clone at 28%. Here again, we could perhaps think that this is a biallelic rearrangement of a single clonal B-cell population, because as you can see, the smaller fragment or the predominant fragment is of shorter length than the second most predominant fragment. And as we all know, PCR tends to amplify shorter fragments faster or better than longer fragments. So perhaps this skewing it reflects the actual inefficiency of PCR when it comes to longer fragments. The most predominant allele over here, which is at 41%, as you can see, is very nicely the 434 V region. It is hypermutated because it's less than 98% homologous, but it has a stop codon and it's out of frame. So one could say, well, it's a good double whammy. It's mutated, good prognosis, and the IGHV 434 in this case is a stereotype subset, which gives you an indolent course of the disease, regardless of hypermutation status. I will deal with this just very shortly towards the end of the lecture. If we look at the minor allele, so this is only 28% of the clone. However, this is the one that has no stop codon, it's in frame, therefore it is a productive allele. And this allele is the one that should be used for hypermutation analysis. The major one is not taken into consideration, only the minor one is taken under consideration. As you can see, it is 98.34% homologous to the germline, therefore it's deemed unmutated, it's bad prognosis. So this allele is not used. Only this allele is used for hypermutation analysis. And this is where the NGS technology is faster and more efficient and more precise and clear. It's because it allows you to differentiate between these two fragments. If you were to do it by Sanger sequencing, you would run into a problem because you would have two sequences, one over another. Stereotype subsets, that's a more recent discovery whereby a very specific sequence of the V region belongs to certain stereotypes. It's a very complicated issue, so I don't have the time to go into that, but it is necessary and imperative that each sequence that you analyze for CLL, you also analyze for the stereotype subset. Again, it's a website that's available freely to anyone where you type in your sequence and you get the analysis done for the stereotype subset. And it's important to note that there's 5 subsets that dictate prognosis regardless of the mutation status of your V fragment. So subset number 1, whether it's hypermutated or not, gives a poor prognosis, has an aggressive clinical course. Same with subset number 2. Subset number 4 will give you an indolent course regardless of the mutation status. Same for subset 5. Subset 8 is associated with a higher risk of Richter's transformation. So not only does one need to do the hypermutation analysis to see the homology to the germline sequence, one needs to do the subset analysis in order to see whether there's an overriding stereotype that is independent of your mutation status. The paper published by Rosenquist and Gia and so forth in 2017, it's the updated ERIC recommendations. We had a fellow here work through this paper and basically create a flow chart that you can follow. And the first question is whether there's a clonal IgHV sequence. You have either no, you have yes, only one, or you have yes, more than one. And then you basically follow this flow chart in order to see how you're supposed to report and what you're supposed to report. Or there might be some additional sequencing and analyses that should be done in order to arrive to the final conclusion. So I found this paper to be very, very helpful because it really delineates how this whole analysis should be done. So now I thank you for having listened to this presentation, and I now pass the microphone to Dr. Bevan Tandon. Thank you very much.
All right, thank you, Dr. Monczak. It's a privilege to be able to present. I will be discussing also utility of next generation sequencing, routine clinical laboratory evaluation of lymphoid malignancies. And my presentation is enabled by InVivoScribe for disclosure. And I will illustrate the clinical utility of NGS in the routine clinical diagnostic evaluation of lymphoid malignancies, first focusing on evaluation of clonality in mature B-cell and T-cell non-Hodgkin lymphomas and leukemias. I'll also briefly touch on and amplify some of the topics that were mentioned by Dr. Monczak and present on IgHV somatic hypermutation analysis and CLL/SLL. I'll also close out then with minimal residual disease assessment in lymphoid malignancies. So for the first part on just clonality detection, as Dr. Monczak emphasized, the somatically recombined VDJ segment cassettes can serve as unique molecular fingerprints for different clonal cellular populations in lymphoid processes, whether hyperplastic or reactive or malignant. Lymphoid malignancies characteristically harbor unique B-cell and T-cell receptor gene rearrangements. TCR and IgH loci consist of somatically recombined VD and J region DNA segment cassettes distributed across chromosomes 14 and also chromosome 7, and the index DNA sequences can be correspondent to functional IgH and TCR gene rearrangements and can identify lymphoid populations of interest. So depicted here is a polyclonal cellular admixture, and when you do size separation PCR, traditional methodology, you'll expect a normal Gaussian bell curve distribution of sized products, differently sized products. And NGS read data can also reflect this by a variety of unique TCR or IgH sequences. In oligoclonal cellular admixtures, you typically see a predominance of only a few clonal peaks on PCR, and then similarly depicted here, you'll see that reflected in your NGS sequence data, and then of course monoclonal populations that are homogeneous will harbor unique VEJ rearrangements that would be expected to show up as a predominant single clonal spike on PCR, and then you could see that reflected in NGS read data as well. Now, I will say from clinical practice, this is a gross oversimplification because you typically resort to B-cell clonality or T-cell clonality detection in diagnostically challenging cases. So when the clonal signal patterns on PCR are easy to assess and determine, then it's fairly straightforward for clinical practice. But we often get many borderline cases that are difficult to interpret by PCR, and mycosis fungoides is especially notorious for challenges related to clonality detection. So mycosis fungoides is the most common cutaneous T-cell neoplasm. However, diagnosis is often challenging. Histologic features may overlap with reactive inflammatory dermatoses, and serial biopsies are often typically required, especially for diagnosis of early patch or plaque stage disease. Demonstration of clonal TCR gene rearrangements is often critical in this setting. However, gold standard PCR is known to suffer from insensitivity, and data interpretation may be subjective. So I'll just go into a little bit of detail on a paper published in Journal of American Academy of Dermatology from some of my former colleagues at Washington University in St. Louis. So they performed T-cell clonality and compared detection sensitivity by conventional PCR using the Eurovet Biomed 2 PCR primer set to NGS Illumina sequencing among 34 histologically gold standard FFPE specimens of mycosis fungoides. And the NGS cases were deemed clonal if the most frequent 2 TCR sequences accounted for greater than 5% of total reads. So it's not infrequent, especially in T-cell neoplasms, to see biallelic or potentially biclonal rearrangements. Here is a summary of the 34 cases assessed, and what is immediately notable, sorry for a busy table, is that among capillary electrophoresis results, only a subset are showing the expected clonal positive results. So these were histologically and clinically gold standard cases of mycosis fungoides, and expected results would be would be expected to be positive for clonal. NGS had clonal results detected in a significantly increased proportion of cases compared to the capillary electrophoresis PCR. So in this particular study, there was less than 50% concordance between NGS and PCR, and 2 cases were appropriately clonal by PCR but polyclonal by NGS. Conversely, 16 out of 19 PCR polyclonal oligoclonal cases were clonal by NGS. So the key capillary electrophoresis PCR sensitivity and accuracy was said to be only 44%, and NGS basically exhibited double accuracy sensitivity for detected clonal populations among these expected histologic gold standard cases. So NGS was concluded to significantly improve upon standard PCR for detection of T-cell clonality in mycosis fungoides. Demonstration of clonal relatedness based on identification of similar TCR sequences at multiple body sites can also be potentially facilitated by this kind of analysis and may assist in diagnosis and exclusion of reactive inflammatory processes. B-cell clonality assessment is an important test in routine clinical hematopathology practice, particularly when morphology or other ancillary testing are suspicious but indeterminate for malignancy. PCR is the widely utilized standard methodology approach in routine clinical laboratory settings. Optimal testing approaches incorporating NGS are not yet well standardized or widespread. So this is a data set that we had generated and presented at a previous Association of Molecular Pathology annual meeting. And we looked at a variety of B-cell infiltrates, malignant by, and also non-malignant by PCR and NGS, tested among FFPE sample substrates as well as liquid marrow, aspirate, and peripheral blood samples. And what is shown here is that PCR and NGS was concordant among 20 out of 21 cases, or 95%. there were 10 clonal B-cell neoplasms and 10 polyclonal cases. What I will mention here is that there was one discordant case in particular, which I'll discuss and illustrate. But I also just want to draw your attention that individual laboratory validation is required because you have different framework 1, framework 2, and framework 3 forward primer sets involved in the analysis. You have to essentially look, but the NGS clonal result is a summary of basically of the variety of primer sets utilized. So in this particular case, that was the one discordant case. It was a 67-year-old female with ocular proptosis. She basically had her globe protruding from its eye socket. It's a pretty dramatic clinical presentation. And in an elderly patient with a head and neck process, you immediately think about predilected marginal zone B-cell lymphomas. MRI studies were performed in that case and were remarkable for a 2.8 centimeter lobulated, homogeneously enhancing orbital mass along the undersurface of the proximal to mid-intraorbital optic nerve segment. So that's actually a pretty unusual clinical site and distribution of disease or presentation for a reactive dacrocystitis or a lacrimal gland inflammatory process if it's a deep into the orbit. Clinically, I was thinking very strongly that this is a lymphoma until proven otherwise. Morphology in that case was really challenging because we only had a very scant fragment available for analysis, and there was an atypical dense CD20 positive B-cell lymphoid infiltrate with a focal plasma cell component present, but flow cytometry was negative for monoclonal light chain restricted B-cell process. And we did perform conventional Biomed 2 primer set IDH and ID kappa gene rearrangement studies by PCR, and they were negative for evidence of clonality. So the conventional morphologic, flow cytometric, and PCR evidence was unrevealing for definitive evidence for involvement by a malignant process, but the clinical and just H&E morphologic appearance is really worrisome for involvement by a marginal zone lymphoma. And in cases like that, what I'll typically do is resort to immunohistochemistry or in situ hybridization staining for plasma cell marker analysis. And in that case, there was a focal skew of in situ hybridization staining for kappa among the plasma cells. So I was really, really worried. And this was one of our most difficult cases of the year. Here's the PCR data on that case. This is the framework 1 primer set PCR output and the framework 3 primer set, and then again you have these polyclonal signal patterns with a good internal positive control signal here. But NGS was subsequently performed, and since Dr. Monczak went into the graphical analysis and data analysis in greater detail, I'll just mention here that for the framework 1 primer set shown here, there's a variety of sequences demonstrated, so it was unremarkable for clonality, but among the framework 3 NGS primer set data, there was 2 predominant sequences identified. And looking in more granular detail on that framework 3 NGS data, there was a clonal ratio between the first and third most predominant sequences in the analysis of greater than 3, which in our laboratory-specific validation would be suggestive of clonality. So in this case, it was a 5x fold change between the first and third. We looked at first and third typically to accommodate for potential biallelic rearrangements in sample. So basically, NGS in this case, given the clinical presentation, was probably the more accurate result. This patient was actually clinically managed with a Rituxan administration, and then they had a full therapeutic response noted months after. So in my mind, this was a clinical and pathologically defined case as a marginal zone B-cell lymphoma with plasmacytic differentiation, where NGS basically, in my opinion, outperformed the traditional PCR and morphologic and flow cytometric assessments. So this was also a paper published in the Journal of Molecular Diagnostics by early adopters and leaders in this field at the Memorial Sloan Kettering Group from Dr. Maria Arcila and Caleb Ho and others. And basically it's showing that using different framework primer sets, you can see different rates of clonality detection among a variety of B-cell neoplasms. So overall, NGS may provide a practical solution for diagnostic resolution of difficult cases in the routine clinical laboratory setting. Interpretation of PCR results for lymphoid clonality detection is known to be subjective, and NGS objectively delineates predominant clonotypic IGH or TCR sequences with single nucleotide base pair resolution and specificity. I don't have that specifically depicted in the previous slide, but to me, that's one of the major advantages, that if you have similarly sized products on PCR, the NGS with a single base pair resolution can delineate individual sequences for clonal populations. NGS may also be useful in the assessment of clonal relatedness among lesions involving disparate body sites. So moving on to IGHV somatic hypermutation and CLL-SLL. CLL-SLL is the most common leukemia diagnosed among adults in Western countries. As Dr. Monczak mentioned, clinical outcomes are known to be heterogeneous, and I will mention the CLL International Prognostic Index. People have talked about a variety of biomarkers over the past years, many years, as being prognostic indicators in this disease, but basically IGHV somatic hypermutation status is one of the most important as per the CLL International Prognostic Index, along with age, stage of disease, serum beta-2 microglobulin levels, and p53 status by Fisher sequencing. And so this was a data set that we had presented at the Association of Molecular Pathology meeting previously. We used to send out to a national reference laboratory for conventional traditional PCR Sanger sequencing, and they would actually rely first on RNA extraction from samples. So sample transit degradation was a major pre-analytic complicating factor. And in this data set, at least, among 25 cases evaluated and sent out, there was a 5% false positive or false analytic failure, where these are flow cytometrically defined CLL, SLL cases that are by definition then clonal for disease. But on the National Reference Laboratory send out, we had 5 out of 25 of these samples fail with no clonal population detected. We were looking at the time on the Ion Torrent PGM Thermo Fisher platform for NGS, and among all 25 cases assessed using DNA from our archives, we were able to discern clonal populations were present. So among 25 CLL-SLL cases evaluated by both gold standard Sanger sequencing performed at an outside reference laboratory and NGS, Sanger sequencing failed to detect a clonal population in 5 out of 25 cases evaluated for 20% failure rate, whereas NGS detected expected clonal populations in all 25 out of 25 cases studied. NGS also demonstrated 100% concordance with the Sanger sequencing PCR results among the 20 out of 25 cases that were evaluable in terms of their somatic hypermutation status. And at least in our hands, we had a 3% limit of detection for clonal populations by NGS. This was one of the 5 cases that had failed from the conventional PCR Sanger sequencing RNA assay approach. It was actually a pretty egregious false negative analytic failure. This was a 54-year-old male with CLL-SLL. He had one of the highest hyperleukocytosis WBC counts I've encountered in clinical practice, 302,000, with an absolute leukocyte count of 285,000. I, expect that they must have emergently leukophoresed the patient to avoid it stroking out. Sanger sequencing IGHV somatic hypermutation performed at the outside national reference lab was reported as no clonal population detected. And this is the peripheral blood smear morphology from this particular case. Flow cytometry confirmed that prototypical CLL immunophenotype, 19.5 co-expression, et cetera. ZAP70 analysis was performed and it was actually negative. And in this particular case, NGS was performed and demonstrated 100% IDH sequence homology as compared to germline most closely matched reference controls, confirming unmutated disease status. And here's a graphical depiction of the VJ family utilization and the percentage of total reads for different clonotypic sequences and analysis. And what was shown here was that not only was there 100% sequence homology confirming unmutated disease status, as would be expected as an adverse feature in obviously a dramatic clinical presentation with a patient with aggressive disease. There was also V321, V321 VJ utilization profile notable. And V321 VJ utilization profile is generally considered also an adverse stereotype B cell subset utilization profile that it confers adverse prognosis irrespective of the somatic hypermutation status. I'll also mention in this case, NGS outperformed the flow cytometry analysis, and that you would expect the ZAP70 to be positive, but ZAP70 is subject to high interlaboratory variability and operator skill at the wet bench. So it's a challenging marker to perform by flow cytometry, and for years people have used it as a surrogate for IgH somatic hypermutation. But now that NGS is a very robust and easily accessible and implementable technology, we were very happy to be able to sunset the previous traditional surrogate biomarker that we had employed in the laboratory, and sunsetting the ZAP70 by flow in favor of the more direct assessment of IgH somatic hypermutation status using NGS was definitely a big win for our laboratory. Now, this is the same paper that Dr. Monczak had alluded to earlier that was covering recommendations for IgH somatic hypermutation profiling in CLL, SLL, and I apologize for reading text essentially in a presentation, but I think it really bears mentioning and amplifies what Dr. Monczak was presenting on earlier, that leader primers are the only recommended option for analysis. That said, in rare cases, when leader primers are unsuccessful at providing a product that can be sequenced and VH framework 1 primers are used instead, but they're discouraged for the determination of somatic hypermutation status, the clinical report should indicate that the use of VH framework 1 primers might underestimate the total number of IgH somatic hypermutations, as the part of the VH domain is missing. And that's exactly what Dr. Monczak was mentioning on the initial part of this presentation. And this principle came into play for our laboratory as we're undergoing optimization and familiarization for initial validation of NGS. And we looked at 50 CLL, SLL cases that had been sequenced using NGS Framework 1 and NGS leader primers. There was an almost 10% discordance rate noted with subtle differences in VJ utilization and somatic hypermutation results based on the differential VJ sequences from Framework 1 specific analysis or the more comprehensive leader sequence analysis. And so here, for example, is the first case. If you assume that 2 to 3% is a borderline gray zone, this was the 4 out of the 5 samples fell in this 2 to 3% somatic hypermutation rate borderline gray zone, whereas by more comprehensive leader sequence analysis, they all showed a greater than 3% somatic hypermutation rate, i.e. mutated and prognostically favorable versus borderline result. And then looking at one of the cases in particular, there was a less than 2% sequence homology notable and 1.33% mutation rate. And so that would imply that it would be unmutated disease, but then looking at the probably more accurate leader result, you have 4.73% somatic hypermutation rate notable for mutated prognostically favorable disease. And there were also some subtle differences in VJ utilization profile delineated. So overall, NGS may confer significant advantages over traditional methodologies. NGS may show improved sensitivity and detection of clonal populations. DNA is an acceptable substrate for IgHV somatic hypermutation analysis, eliminating practical constraints typically associated with RNA Sanger sequencing-based PCR analysis for somatic hypermutation testing. Many labs in the country do perform an initial RNA extraction followed by reverse transcription and cDNA sequencing and PCR amplification. So this mitigates the potential for patient redraw, and especially in the case of potential late add-on requests. NGS may also significantly streamline laboratory workflow. In our hands, we had a very minimal assay hands-on time requirement with 3-day clinical reporting, and we could batch multiplex samples to exploit economies of scale and minimize our costs and labor. And importantly, also just in terms of diagnostic accuracy, I will mention that discordances in VJ utilization may be notable if using Framework 1 primers only. So I'll move on, and I think, like, in the interest of time, I might have to speed through a little bit for the MRD assessment capability using NGS. Minimal residual disease refers to the presence of leukemic cells below the threshold of detection by conventional morphologic methods. There are different cut points for very commonplace diseases, including plasma cell multiple myeloma, as 1 in 10 to the minus 5, defining a clinically significant MRD threshold, as well as in acute lymphoblastic leukemias, for example. They typically say 0.01% or 1 in 10 to the 4th should be a recommended assay analytic sensitivity, whether by flow cytometry or molecular methods. So I will say that there are significant challenges associated with the classical methodologies for MRD approach. The assay limit of detection for MRD flow cytometry is typically limited and ranges between 10 to the minus 3 and 10 to the minus 4. Flow cytometry data, especially near the assay limit of detection, may be highly subjective. I've had many cases where I've had to look at flow cytometry and, for example, paucicellular infiltrates or children with ALL, and I can say that when you get down to reviewing those dot plots at the lowest limits of detection for 0.1% or less, it's very, very difficult to be confident that you're dealing with persistent presence of leukemic populations. Also, the flow cytometry may be complicated by cellular fragility of neoplastic populations, and the cellular proportionality can also be skewed in flow cytometry analysis due to cellular fragility, and that's a well-known phenomenon for flow cytometry evaluation for plasma cell populations, and also diffuse large B-cell lymphomas can sometimes show cellular fragility and skewing for populations percentages. Index leukemia-associated immunophenotypes can also sometimes significantly overlap, and non-specifically with normal marrow regenerative precursors. A classic differential diagnosis in conventional hematopathology practice is hematogone hyperplasia versus residual B-ALL. It's easy when you have, straightforward cases and you can see a good smear pattern on CD10 versus CD20 on flow cytometry or et cetera. But there are cases that can be very difficult by flow cytometry. Although PCR typically demonstrates a greater depth of analytic sensitivity compared to flow cytometry, there's challenges therein as well. So amplifiable signature gene fusion transcripts may be present in only subsets of disease. So for example, less than half, depending on literature and what you read, it might be 20 to 30% of adult ALL may show a Philadelphia chromosome positive chimeric fusion transcript, and even lesser in pediatric patient populations. So the signature of interest that you would otherwise interrogate using PCR may not be present in all instances of disease, whereas if you're targeting IgH rearrangement, you expect that to be positive in all neoplastic B-cell processes, for example. Even among B-cell lymphomas with disease-defining translocations that could be assessed by amplification PCR, et cetera, there are significant challenges associated with breakpoint heterogeneity that can complicate PCR design. So it's well understood, for example, in mantle cell lymphomas, virtually 100% of cases are defined by IgH CCND1 gene fusion for 1114 translocation, essentially. And yet there's significant heterogeneity in the major translocation cluster region that PCR is traditionally understood to be only about 50% amplifiable, and then hence serial, capable for amenable to serial monitoring using PCR. So MRD detection based on PCR amplification of clonal IgH rearrangements also can be challenged and limited due to a requirement for patient-specific primer design, limiting its practical utility. This was a case, the slide material is courtesy of Dr. Caleb Ho. This was presented at the previous Association for Molecular Pathology meeting, and it was a patient who had a history of T-cell lymphoblastic lymphoma leukemia, T-ALL, and he had undergone an initial stem cell transplant and followed by relapse with subsequent treatment, including a second allogeneic stem cell transplant. And this was a pretty dramatic clinical presentation because this was a relatively young patient with T-ALL having undergone a second stem cell transplant. And so this is at the initial diagnosis. There's easily discernible blast population here on flow cytometry, and NGS data shows that there was a predominance of two clonotypic index leukemic sequences correlated to two PCR predominant peaks, notable on PCR. And so this shown here is actually 1 month after the patient had undergone second stem cell transplant. And in the 1 month post second stem cell transplant, the NGS data, similar to the initial diagnostic samples, shows readily that there's a 148 base pair length product and 144 base pair length product at very low proportion of total reads, less than 1% each. The PCR is clearly readable and discernible for the same index by two leukemic populations. Flow cytometry was positive in that case, and there were also 12% blasts on marrow morphology as per smear review. However, now looking at a subsequent PCR analysis, the data was so noisy, you can't readily look at PCR and determine, this is 1 month after the second stem cell transplant, you can't readily discern that there's persistence of the same index leukemic populations. But the NGS data in this particular case did show persistence of that 148 base pair length product seen initially. And now 6 months after the second stem cell transplant, the other 144 base pair length product was identifiable in 0.02% of NGS reads for 0.02% MRD level. And at this subsequent time point, for example, there was a very, very low level of abnormal T cell lymphoblast by flow cytometry and only 1% blast by morph. And PCR is very difficult to discern clonal relatedness. And then 8 months post second stem cell transplant, the same story, that the PCR is relatively indeterminate for correlation for persistence of disease. Flow cytometry and morphology were also unremarkable, but in this last analysis, 8 months post second stem cell transplant, there's persistence readily identifiable and discernible from the NGS data for those index leukemic sequences. And this is also courtesy of Dr. Caleb Ho and working with Maria Arcila and the Memorial Sloan Kettering group, that they compared NGS to flow cytometry and other conventional methodologies for MRD assessment and B-ALL and B-cell lymphomas as well as plasma cell neoplasms. And what I'll draw attention to is that in B-ALL, for example, there was only a 91% concordance with NGS outperforming conventional flow cytometry in almost 10% of cases. So in summary, compared to traditional PCR, NGS may improve sensitivity and specificity of clonality detection in B-cell and T-cell non-Hodgkin lymphomas leukemias. Next-gen sequencing may confer significant practical and technical advantages compared to traditional methodologies for IDHV somatic hypermutation analysis in CLL/SLL, and NGS may serve as a technically robust solution for sensitive and specific MRD analysis in lymphoid malignancies. With that, I'd like to just close with acknowledgements. In our laboratory, Dr. Min Yu and Latish Shrestha helped generate the data on comparing the Framework 1 and Framework and the leader sequences for IGHV somatic hypermutation analysis. Within a 6-week time frame, we had our complete optimization and familiarization completed, so it really attested to their skill and also the ease of use of the NGS assays available. I would like to also acknowledge and thank Dr. Roger Hubbard, CEO and founder of Molecular Pathology Laboratory Network, for his vision and prioritizing resource allocation for us to work on NGS for the applications that we have discussed. And also Dr. Caleb Ho at Memorial Sloan Kettering Cancer Center for some of the slide material, working also with Maria Arcila. So with that, I will close and say thank you, and it was a privilege to present. Thank you.
We have now reached our closing time. On behalf of InVivoScribe and AMP, we want to thank everyone for your attendance today at this webinar. We also once again want to thank Dr. Monczak and Dr. Tandon for their fine presentations. Please note this session has been recorded and that these presentations will be made available via the AMP Education website. You may also reach us at www.invivoscribe.com. In the interest of the questions that were posed to us, we will do our best to be able to respond back to those people directly. Thank you very much. This session is closed.